My name is Jane Basile, and I am a microbiologist with the Centers for Disease Control and Prevention at the Division of Vector-Borne Diseases in Fort Collins, Colorado. This video is intended as an aid to diagnostic testing of patients suspected to have Zika virus infection. The material is aimed towards trained laboratorians who have previous experience with viral diagnosis. The format used here is the same as which the CDC uses for chikungunya virus IgM ELISA and other arboviruses. While the reagent specifics given in this video are for Zika virus, appropriately standardized reagents can be substituted into this test for other arboviral agents. The recent designation of Zika MAC ELISA for use under the FDA Emergency Use Authorization, or EUA, requires that laboratories in the U.S. performing this test must be trained and proficient according to the federal guidelines prior to testing patient samples. Information on this is given in the reference section at the end of this video. Laboratory diagnosis of Zika virus is best performed on very acute phase specimens using real-time RT-PCR. For RT-PCR, samples should be obtained at 7 days or less after onset of symptoms. However, not all samples are collected in the acute phase. Serology consists of IgM ELISA, sometimes referred to as MAC ELISA, and confirmatory plaque reduction neutralization test. This instructional video describes the proper way to perform an IgM ELISA for Zika virus and covers technical details, titration of reagents, and interpretation of results. Reagents used in the video are those currently used by the CDC Arboviral Diseases Laboratory. Those which are commercially available may be purchased from other sources, and dilutions used in this video only pertain to the lot numbers currently being used. Titration may be necessary when substituting reagents and under your own laboratory conditions. Currently, there are no commercially available kits for laboratory testing of Zika virus infections. Because of the cross-reactivity seen among flaviviruses, it is preferable, but not required, that dengue should be tested for concurrently with Zika, and dengue IgM ELISA kits are commercially available from multiple sources. Confirmatory serologic testing, the details of which are beyond the scope of this video, should always be performed using Zika and dengue viruses. A laboratory risk assessment should be conducted prior to using this method. Zika virus is a SALS level 2 agent, and thus precautions must be taken in handling clinical specimens. The most common specimen types used in IgM ELISA are serum and cerebrospinal fluid, and there is potential for these specimens to contain live virus or other unrelated etiologic agents. The reagents used in the CDC IgM ELISA are all non-infectious. Non-FDA regulated laboratories may use infectious antigen, although this is not recommended. Laboratory safety precautions include the use of lab coats or gowns, gloves, eye protection, and certified HEPA-filtered biosafety cabinets. It is recommended that manipulations of the specimens and plate washing are performed in the biosafety cabinet, and that liquid waste is decontaminated using bleach prior to disposal. In laboratories where the certified biosafety cabinet is not available, it is recommended that specimens are heat inactivated using a water bath or heat block set at 56 degrees Celsius for 30 minutes, and if chikungunya virus is suspected, at 56 degrees for 2 hours. This will not adversely affect the IgM ELISA results. Further information on the safe handling and transport of SALS level 2 agents can be found on page 33 of the CDC NIH publication Biosafety in Microbiological and Biomedical Laboratories, 5th edition, at the link shown on the screen. The correct interpretation of results from either molecular or serologic methods used for Zika virus laboratory diagnosis is heavily reliant on the information obtained from the patient. At a minimum, you should obtain the following: place of residence, places traveled to in the past year and dates of travel, date of onset of symptoms. This information may be missing if asymptomatic persons are being tested, in which case it should be noted that the individual is asymptomatic. Date of collection of each sample, prior history of flavivirus infection, and whether the patient has been vaccinated for yellow fever, and if so, when. Further information can be found on the Zika infection page of the CDC website. Serum is the best and most common sample type for this testing, as it is generally easy to obtain and the sample needed is small, leaving the remainder for confirmatory testing if indicated. Cerebrospinal fluid, or CSF, is also acceptable, but volumes needed are larger. Plasma and other sample types have not been evaluated in the IgM ELISA. Whole blood is unsuitable for serology, and very bloody serum may give unreliable results. Do not accept samples drawn into anticoagulant tubes. Samples should be shipped on ice pack and kept at 4 degrees C prior to testing. If the sample was taken less than 7 days after onset, molecular testing should be performed first. Ideally, paired samples should be obtained, with the second sample being drawn 7 to 14 days after the first. In reality, this is often not practical. Complete information on how to obtain appropriate samples for testing can be found at the link on the screen. Immunoglobulin M is typically the first antibody to be detected in acute primary Zika virus infections, and it persists for weeks to months or longer. IgM levels are generally higher in primary infections than in secondary flavivirus infections, where the patient has experienced a previous flavivirus infection. The Zika IgM ELISA is a qualitative assay. Because IgG accounts for the majority of the serum antibody fraction, the IgM ELISA is configured to select for IgM, which maximizes the sensitivity of the assay. This is accomplished by coating the microtiter plates with anti-human IgM antibody, which attaches to the IgM in the serum, and the IgG is washed away. After serum addition, antigen is added, which is the source of the specificity of the test. An anti-flavivirus horseradish peroxidase conjugate is used to detect the reactions, and a TMB substrate is used to develop the results. For the non-commercial components of the test, U.S. laboratories may contact CDC using the information given at the end of this video. These may be made available on a case-by-case basis and are subject to restrictions of the EUA. For international labs, please contact your national reference laboratory. You will need the following: automatic microplate washer, programmed for 5 washes of 300 microliters per well, plate reader with 450 nanometer filter and printer, refrigerator at 4 degrees C, incubator at 37 degrees C, calibrated pipetters, P10, P200, P1000 and multi-channel, microtiter plates, high binding. Currently, we use Imulon 2HB flat bottom 96 well plates, pipette tips that are non-blocked, serum dilution tubes and stoppers, reagent reservoirs or boats, Ziploc bags or sealed plastic containers, paper towels. For details regarding reagents, please see the list referenced at the end of this video. For laboratories covered by the EUA only, sources of reagents and all details regarding storage and handling of these must be adhered to according to the EUA protocol. To begin the IgM ELISA, mark the locations of the sample on the plates using a Sharpie as shown here. All samples and controls are tested in triplicate on both viral and normal antigens. Outside wells are typically not used, to avoid inconsistencies that tend to occur in these wells. A maximum of 8 test specimens can be tested on a plate. A positive and a negative control should be included on the plate. Reconstitute the anti-human IgM, which serves as the coating antibody, and store according to the manufacturer's instructions. Here we have used 50% glycerol to reconstitute the coating antibody. Prepare the coating antibody solution, where 4.5 ml is required per plate, plus a little extra for pipetting. The anti-human IgM used here is diluted 1 to 2,000 in coating buffer. When the reactivity of the coating antibody is unknown, the antibody should be titrated to determine the optimum dilution according to the method given at the end of the video, using the manufacturer's dilution recommendations as guidance. Add 75 microliters per well of diluted antibody to each of the 60 test wells. Cover the plates using an empty plate or plate cover and place in the refrigerator at 4 degrees C for a minimum of overnight and for a maximum of 7 days. If multiple plates are being processed at once, it is okay to stack the plates. When you are ready to run the test, remove the coating solution from the plates by dumping it into the sink and blotting the plates on paper towels. A plate washer should not be used for this step. The blocking buffer is made of 5% non-fat dry milk in PBS with 0.5% tween 20 and can be stored at 4 degrees for up to 3 weeks. Block the unused binding sites on the plate with 200 microliters per well of blocking buffer. Cover the plate and leave to incubate at room temperature for 30 minutes. While the plates are blocking, prepare the test samples and controls. Test samples are best prepared the day of use, but can be prepared up to 1 day ahead of time and refrigerated. Dilute the test serum samples 1 to 400 in wash buffer by adding 1 microliter of serum to 400 microliters of wash buffer. The negative control should also be diluted to 1 to 400 in wash buffer. If cerebrospinal fluid is the test sample type, it should be used undiluted or a maximum dilution of 1 to 5, and a negative CSF control should also be placed on the plate at the same dilution as the test specimen. Due to volume restrictions, it is reasonable to test CSF in a single well on viral and normal antigens. Samples should be diluted in a biosafety cabinet or should have been heat inactivated at 56 degrees C for 30 minutes to 2 hours if a safety cabinet is unavailable. Dilute the positive control according to a previous titration, where the resulting optical density should be around 1.0. This is to avoid wastage of positive control. In the test shown here, we are using the flavivirus group-reactive chimeric humanized monoclonal antibody 6B6C1, diluted at 1 to 3,000 in wash buffer. Reconstitution of the chimeric positive control is done using water, and once rehydrated, the control may be aliquoted and stored at -70 degrees C. Upon defrosting, the aliquot may be kept at 4 degrees C for up to 6 months. If Zika positive serum is used, it should be diluted to at least 1 to 400, according to a previous titration. Wash the plate using a plate washer located inside a safety cabinet, if at all possible. The waste collection vessel should contain bleach according to your safety regulations to allow for inactivation of any pathogenic substances prior to disposal down the drain. Use 5 washes of 300 microliters per well. For testing not covered under the EUA, if a plate washer is unavailable and the samples have been heat inactivated and the viral antigen is confirmed to be inactivated, wells can be washed by hand by pipetting 200 microliters of wash buffer into each well and dumping out for a total of 3 washes. Vortex or mix the diluted test samples and controls immediately prior to use. Add 50 microliters of each serum sample to 6 wells per plate and do the same for the positive and negative controls. Cover the plate and place it in a sealed container with wet paper towels to keep the environment humid, or use a Ziploc bag with paper towels. Place in a 37°C incubator for 1 hour. For the CDC Zika viral and normal antigens, store the lyophilized products at -15 to -25 degrees Celsius and rehydrate with 0.25 ml of sterile water. Aliquot and store at -15 to -25 degrees C for up to 1 year. If an aliquot is not entirely used up in one run, the remainder can be refrozen and used later. Discard at the end of 1 year. Do not store the antigens at 4 degrees C, as they will deteriorate rapidly. The antigens can be used to detect IgM caused by all known Zika virus strains. The Zika virus antigen here is used at a 1 to 160 dilution in wash buffer, and normal antigen is always diluted the same as the viral antigen. For non-US labs, if the antigen in use is infectious, it should be handled in a biosafety cabinet. US labs should only use inactivated or non-infectious antigen. When using a new lot number of antigen, refer to the material at the end of the video for information on how to titrate it. Wash the plate using the plate washer. Vortex or mix the antigens before use, then add 50 microliters of the viral antigen to the sample wells of the even-numbered columns on the plate, which correspond to the left side wells for each sample. Add 50 microliters of normal antigen to the odd-numbered columns on the plate, which correspond to the right side wells for each sample. Cover the plate and place in the humidified container. Incubate the plate overnight at 4 degrees C. This is an important step for the sensitivity of the test. Shortening the incubation, for instance by incubating at 37 degrees for 2 hours, will cause low positives to be missed. The detection conjugate used in this test is made from flavivirus group-reactive monoclonal antibody 6B6C1, which was made to St. Louis encephalitis virus. The monoclonal antibody is conjugated to horseradish peroxidase enzyme. This product is available commercially and should be reconstituted and stored according to the manufacturer's instructions. The product used in this video was made at the CDC, and after reconstitution in water, it is kept in a foil-wrapped container at 4 degrees C for up to 1 year. Dilute the conjugate in blocking buffer. Each plate requires 3 ml plus a little extra. Commercial products will need to be titrated to determine the working dilution, using known working dilutions of the other test components. Video footage of this procedure is given towards the end of this presentation, and also in a document at the end of this video. The lot number of the conjugate used here is diluted 1 to 5,000 in blocking buffer, which is 1 microliter in 5 ml of blocking buffer. Make this dilution shortly before use and do not store. Wash the plates. Add 50 microliters of diluted conjugate to all 60 wells. Cover and incubate the plate in a humidified container at 37 degrees C for 1 hour. In the meantime, take the TMB substrate out of the refrigerator and bring it to room temperature. There are many commercial sources of TMB substrate available, and they should be used according to the manufacturer's instructions. Here we are using Neogen K Blue. Wash the plate and then turn it 180 degrees and wash again for a total of 10 washes. This is to ensure even washing of the wells. Blot the plate on paper towel to remove any excess wash buffer. Add 75 microliters of substrate to all 60 wells. If substrate is being added to multiple plates, care should be taken to avoid substrate contamination from the pipette tips. If the substrate in the reagent reservoir turns blue, discard the substrate and replace the reservoir with a clean one. Place in a dark place, such as a drawer, or under several layers of paper towel at room temperature. Plate covers are not necessary at this point. Set a timer for 10 minutes. Turn on the plate reader to warm up. After 10 minutes, add 50 microliters of 1 normal sulfuric acid to each well to stop the reactions. Non-EUA labs can use 75 microliters of TMB stop solution to all the wells instead. Also add stop solution to 1 or more wells on the outer edge of the plate to use as blanks. In both cases, avoid making bubbles in the wells as this will affect the reading. If bubbles occur, use a small, sharp object to burst them. Wait 1 minute before reading the results. Read the plate at 450 nanometers and print out the results. In this example, the value of the blank has been removed, but it is usually 0.04 or less. Subtract the mean optical density of the blank wells from all of the test wells, and then determine if the test is valid. Calculate the mean OD of the negative control serum. If the mean of the optical density of the negative control reacted on the viral antigen is less than 0.2, you can proceed. If it is equal to or higher than 0.2, it is recommended that you repeat the test. Determine the P/N of the positive control. This is done by taking the mean optical density of the positive control serum reacted on viral antigen, then dividing the product by the mean optical density of the negative control reacted on the viral antigen. If the P/N value is greater than or equal to 2, then the test is valid. If it is not, then the test should be repeated. If a repeat test yields invalid results, the reagents may require retitration. On a valid plate, calculate the mean optical densities for each test sample reacted on the viral antigen. Divide the product by the mean optical density of the negative serum control reacted on the viral antigen. This is the P/N for the test sample. If the P/N is less than 2, the result is considered negative. For any samples with P/N greater than or equal to 2, the result needs to be examined for background reaction to the normal antigen. To do this, divide the mean optical density of the sample reacted on the viral antigen by the mean optical density of the test sample reacted on the normal antigen. If the product is less than 2.0, this indicates a nonspecific reaction to the normal antigen, and the results are uninterpretable. If a background reaction is not present, and the P/N is equal to or greater than 2.0 but less than 3.0, the result is considered equivocal. If the P/N is 3.0 or greater, it is considered positive for IgM to the Zika antigen. All positive, equivocal, and uninterpretable results should be confirmed with PR and T. Here are examples of negative, positive, and uninterpretable results. Always examine the results closely. If a sample has, for example, 2 viral antigen reactions with low optical densities and one that is clearly very high, this likely indicates an inconsistent well, and you should repeat the sample. Failure to do so may result in a false positive and unnecessary confirmatory testing. Any IgM or other test results should always be interpreted in the context of other diagnostic test results. other samples from the same patient, dates of onset and collection, travel history, and clinical picture. IgM ELISA is not considered to be a quantitative test. Therefore, positive and negative are relevant, but the p/n's themselves should not be compared directly to one another. Because of the inherent cross-reactivity of flavivirus antibodies with flavivirus antigens, it is important to investigate any positive results for other flaviviruses, such as dengue, using a confirmatory plaque reduction neutralization test before a diagnosis is made. And results should be considered together. A negative IgM result on a sample taken less than 7 days after onset of symptoms is not conclusive and may be due to delayed IgM production. A second sample taken 7 to 14 days later should be requested in the absence of a positive RT-PCR result. Here are some examples of how serologic test results can be interpreted, and all assume that no molecular evidence is available. This is an example of a primary Zika infection. The Zika IgM is positive and dengue IgM is negative, and the same is true for the neutralizing titers. Cross-neutralization tests, that is, tests that are performed concurrently for both acute and convalescent samples if available on all relevant viruses, are usually performed regardless of whether IgM results are positive for one or both of the viruses. If a PRNT titer is less than 10 or negative for one virus and greater than or equal to 10 or positive for the other, then the positive PRNT result is considered to be the infecting virus. This is an example of the significant cross-reactivity that can occur within the flavivirus genus. Both Zika and dengue IgM results have high p/n values, and the infecting virus cannot be identified definitively using plaque reduction neutralization tests, or PRNT. Therefore, a laboratory diagnosis of flavivirus is given. Traditional interpretations where a four-fold difference between positive PRNT titers are used to identify the infecting virus have been abandoned due to the confusion with anamnestic responses in the secondary infections. Here, the interpretation of flavivirus infection avoids errors in the absence of RT-PCR evidence. Here, there is IgM to both Zika and dengue, where the p/n is higher to dengue than to Zika. However, the PRNT shows that there is a higher titer to Zika. Because the PRNT titers are positive for both viruses, it is impossible to say which the infecting virus is, hence the interpretation of flavivirus. This also illustrates the dangers of trying to compare p/n values when both are positive. This is an example of what a past flavivirus infection might look like. Negative IgM results for both Zika and dengue, and positive PRNT titers of equal value. One would usually not perform PRNT on a sample with negative IgM results. Here, neither IgM ELISA nor PRNT give positive results, indicating that this patient has not been infected at any time with either of these viruses. This is an example of where IgM and PRNT give opposing information. A second sample taken 7 to 14 days later would be needed to attempt to give a laboratory diagnosis, and even then, a result more informative than this might not be forthcoming. As a general rule, primary infections are fairly easy to diagnose via laboratory results. Those who have lived for part of their lives in a dengue endemic area and will likely have had prior exposure to one or more flaviviruses are much more difficult to give a definitive laboratory diagnosis for. Hence, the importance of clinical correlation cannot be stressed enough. When you receive reagents from CDC, we recommend that you try them out first at the recommended dilution shown on the product insert. For instance, if it says use up to 1 to 160, then use it first at 1 to 160. See how the test looks using the positive and negative control serum. Titrate reagents if needed, one at a time after that. For labs purchasing commercial conjugate, you will need to titrate the product before use in the test. This is also true for new lot numbers of the other reagents, and the following will serve as an example of how to do this. In a 96 well plate, mark off 4 columns containing 6 rows. Coat and block the plate according to the standard IgM ELISA instructions. Add 50 microliters of positive control at a normal working dilution to the first 2 columns. Add 50 microliters of negative control at a dilution of 1 to 400 to the third and fourth columns. Cover and incubate at 37 degrees C for 1 hour. Wash the plate and add 50 microliters of Zika antigen at the normal working dilution, in this case 1 to 160, to the first and third columns. Add 50 microliters of normal antigen at the same dilution as the Zika antigen to the second and fourth columns. Cover and incubate at 4 degrees C overnight. Here, the conjugate will be diluted down at 1 to 500, 1 to 1000, 1 to 2000, 1 to 4000, 1 to 8000, and 1 to 16,000. Add 1 microliter of conjugate to 500 microliters of blocking buffer. Vortex. Put 50 microliters of blocking buffer into the bottom 5 rows. Put 100 microliters of the 1 to 500 diluted conjugate in each well on the top row. Take 50 microliters out of the first row and transfer it to the second row. Mix 3 to 4 times. Repeat these steps down to the final row. Discard the final 50 microliters from the bottom row. Incubate the plate for 1 hour at 37 degrees C. Wash the plate 10 times and add 75 microliters of substrate per well. Place the plate in the dark and incubate at room temperature for 10 minutes. Add 50 microliters per well of stop solution and read at 450 nanometers after 1 minute. The goal is to choose a dilution where the positive control gives an optical density of between 1.0 and 0.8, and concurrently gives an optical density of less than 0.2 for the negative control, ideally 0.05 to 0.1. Here we can see that the OD of 1.0 lands between the 1 to 4000 and the 1 to 8000 dilution. For this particular product, we chose 1 to 5000 as the working dilution. You should always test the working dilution using the standard format and the control sera prior to using with patient samples. Thank you for watching this video and for adding this test to your laboratory testing repertoire. We at the CDC are committed to public health and excellence in testing, which can be best accomplished with national and international laboratory support.